as of yesterday, there are 12.1 million people who have COVID-19 across the world and over 541,000 deaths. We crossed a very significant threshold, 500,000 deaths from COVID worldwide. In the United States, there were over 3.1 million infections and more than 133,000 deaths. In the last 3 weeks, and I just happen to know this because I was not looking at this for 3 weeks, the number of infections in the US has increased by 50%. Another way of saying this is that in the last 3 to 4 weeks, there were 1 million new infections, while in the preceding 14 weeks, when we thought things were bad, there were 2 million infections total. The number of new cases are rising in 45 states. In 13 states, the number of cases are at least 60% higher than they were just 2 weeks ago. In Florida, Georgia, Louisiana, Tennessee, and Nevada, the number of cases are at least 100% higher than they were 2 weeks ago. So if that sounds like things are accelerating in the wrong direction, that is correct. ICU beds are filling up as well. The following states have 70% or more of their ICU beds already filled: Arizona, Nevada, Texas, Georgia, Kentucky, Tennessee, Alabama, and West Virginia. Nearly half of the ICU units in Florida are already full. The death rates from COVID are also starting to rise in some states. I think you may have heard some argument that the number of cases are going up because we're testing more, but they're not so sick. That's actually not true. The fact that the ICU beds are filling up is one indication of that. The other is that the death rates are going up, and this is expected because you don't expect the death rate to go up until about 2 weeks after the new cases are going up. So we're seeing that now. Arizona, Texas, South Carolina, and Nevada in particular are notable for this. It would be reasonable to expect that we won't see as many deaths, only because now we have a couple of proven treatment that actually help. So I'm sure that hopefully doctors are using them appropriately. On the transmission front, a lot of scientists have been saying that COVID is being spread not only through droplets from coughs and sneezes, but also is airborne or aerosolized. This is actually a very important distinction because droplets, when you sneeze or cough, it falls down to the ground quickly, relatively speaking, and then it ends up contaminating surfaces and not stay in the air for so long. Airborne, when the virus is aerosolized into the air, it actually can stay there for quite a while, and it may still be in the air when someone else walks into where you've been breathing. The WHO, which has been fairly adamant that this is not the case, has grudgingly admitted, I think this week, that this airborne spread cannot be ruled out, particularly indoors. It doesn't really make a huge difference as far as the community is concerned, except that I think it just means that this thing is very infectious. We already kind of know that, but in the hospital, for example, when we talk about airborne precautions versus droplet precautions, we get revved up even more for airborne transmission. The good news for most people is that the mask will prevent either airborne or droplet transmission. But to date, only 22 states mandate mask wearing of some kind in public spaces. Notably, the governor of Texas just finally mandated mask wearing in public spaces on July 3rd, but only in counties with 20 or more active COVID cases. And Florida, despite its sort of increased numbers, still has not mandated mask wearing. One item I wanted to pass on regarding the prevention of transmission is the FDA has listed some hand sanitizers that are toxic. It needs to be disseminated to our community. What happened is that hand sanitizers have to meet certain standard of ethanol percentages for it to be effective. And these particular sanitizers actually has methanol, which is just one letter change, but it's hugely important because methanol can be absorbed through the skin and is toxic to humans. Basically, in the old days, people used to make moonshine, and that they make wood alcohol, which is methanol, and they drink it and they go blind. And so this is when you start putting sanitizers on your hand that has methanol, there are a lot of bad things that can happen. The reason why I wanted to highlight this was that it happens that all the products listed by the FDA with this problem were produced in Mexico. So it may be relevant to some minority communities. There are still 145 candidate vaccines, 22 are in human studies. The big news this week was that the NIH, National Institutes of Health, announced the creation of a COVID-19 prevention network to test vaccines and other types of prevention of COVID. They also launched a site, website where people who want to participate in vaccine studies can sign up.
Recent analysis of 1.5 million CDC records of COVID tests found that during the period of stay-at-home orders, COVID rates fell for all groups except for Latinos, whose rates surged the whole time during stay-at-home. The CDC data also suggests that COVID-19 transmission in suburban and rural regions sometimes outstrips that in densely populated urban cores. And so the recent outbreaks of COVID-19 among California farm workers in counties such as Imperial County, what we're talking about today, or other places like Oxnard or Hanford, illuminate the central role of the workplace in COVID-19 transmission in rural and suburban geographies. In our report, in our brief, we examined the relationship between the percentage of households in a county in which people worked and lived below a living wage. And so for those of you that might be unfamiliar with the term, a living wage is the minimum amount that someone needs in order to avoid consistent and severe housing and food insecurity. Our analysis looked at the relationship between the percentage of households in a county that had workers and lived below a living wage, and COVID positivity test rates. And we found a strong relationship between low wage work and COVID-19 positivity. We also identified the industries that have the greatest prevalence of low wage workers and the likelihood of federal paid sick leave by the industry of workers, based on the exemptions that exist in the bill. And so our main findings were that, first off, 18 of California's 58 counties, as of a couple days ago, had COVID-19 positive test rates above 8%, right? The state set certain thresholds for opening local economies back up, and one of the stipulations was that positivity rates need to be below 8%. As of July 8th, California had 18 counties that had positivity rates above 8%. And what we found was a striking relationship between what we called county level worker distress, which is the percentage of households working and making less than a living wage and living in households that were larger than the state average. So we found a relationship between worker distress and positivity rates. Most counties that were above the state average with worker households making less than a living wage and the size of the household, most counties that were larger than the state in those two measures were on the state's COVID-19 watch list with positivity rates above 8%, 12 out of 15. This included Imperial, which has 35.8% of households in Imperial are characterized by workers making less than a living wage. That's third highest in the state. There's an average of 3 people per household in Imperial, which is fourth highest in the state out of the 58 counties. On the flip side, most counties with a low worker distress, those that have lower than average percentages of worker households making less than a living wage, or lower than average size households. Most counties with low worker distress were marked by low COVID positivity. Only 4 of the 39 counties that had low worker distress were on the state's watch list of counties that have above an 8% COVID positivity test rate. What we're finding is that there's a relationship between worker distress and COVID positivity that's constant across rural, suburban, and urban geographies. One other thing we did in the brief was to look at positivity by industry. One of the other things we looked at was the percentage of worker households making less than a living wage by industry. So we identified some industries in which worker distress would be highest. Agriculture was at the top of the list, followed by accommodations and food services, administrative and support and waste management, transportation and warehousing, and retail. So we've been hearing stories about farm workers. We've been hearing stories about Amazon workers, warehouse workers. We've been hearing about stories about grocery retail workers falling sick on the job. Essential workers who have no choice but to show, essential workers who are not mandated to stay at home, many of them who are low-wage workers and fear the repercussions of missing a day of work because they risk constant and severe housing and food insecurity even when they work. And so our recommendations are reporting COVID-19 positivity by industry, so that we can understand how industry's trends affect COVID transmission, and so that our policy can play a critical role in developing appropriate workplace health and safety standards. We also recommend improved workplace health and safety standards, which not only protects workers, but would then protect the communities that they return to after working. And lastly, we recommend a greater safety net for workers in essential jobs. Millions of workers, most workers are exempted from the Families First Coronavirus Response Act stipulation of paid sick leave. About 80% are exempted because they work for employers that have over 500 employees or under 50 employees. The act only applies to those persons who work for private employers between 50 and 499 workers, and most Americans don't work for firms of that size. And so our last recommendation is a greater safety net for workers in essential jobs, because millions lack access to traditional unemployment benefits like undocumented immigrants, guaranteed sick pay because of the gaps in the FFCRA, or even affordable health coverage. Such workers may have no choice but to work. And so consequently, if we were to implement better health and safety standards by industry, if we were to develop them and to implement them, it would still be necessary for us to have a safety net in order to enhance the policy efforts to reform workplace health and safety standards.
In the Imperial Valley, we have been dealing with endemics for a very long time. We have been dealing with deep cuts to our frontline workers, to our healthcare, who have never ever had the necessary resources to deal with the population that lives here, the economy that was created here for the border region. We are a major port. When we think about ports, we need to look at the bigger picture, not just the Bay Area, not just New York, not just Los Angeles or the San Diegos. We're a major inland port that also needs to get the same type of infrastructure and investment from the federal government and the state. We are interconnected in Mexico. It's not about pointing the fingers across each way. It's about recognizing and acknowledging the fact that we have a much larger population. We're a metropolitan area. Just because California sees us all the way to the border and then stops their characterization of our border region and looks at it as a rural, sparsely populated area, that could not be farther from the truth. And the legislature has failed to recognize our daytime population, and previous administrations have failed to recognize our population. That's why we were underprepared, under-equipped, and years of deep cuts to our nonprofits, to our healthcare locally, have also put us in a reactive situation right now. It is natural to understand that whenever you have a crisis, as we do right now, that you're going to deal with the crisis in the most critical, those most critical ill, those are in the hospital, in the emergency care, and retool and re-equip. From conversations that I've had with our local hospital, which I stay more in contact with, Pioneer Memorial Healthcare District, who is one of our partners, and they have the room, they have the space, they need the medical staff. The county has, in recent reports, have reported that we are medically underserved. We don't have the medical staff. We don't have the doctors. We don't have the equipment. And as it was mentioned by the medical expert earlier, we cannot rely on shipping our patients, our critical ill, to other hospitals, because we put them at risk, not only to the patient, but also to other regions. We have to, now that we've been months into this crisis, into this pandemic, We need to now have peripheral vision, and our elected leaders. I'm very thankful that we have leaders such as our Assembly Member Eduardo Garcia, our Governor Gavin Newsom, because if there was ever a time we get to choose our leaders, we want to make sure it's leaders such as them. But now we need to inform them. Again, I want to reemphasize that I'm thankful that Dr. Flores was able to characterize the inequities that exist here. If we don't take the war on COVID into our neighborhoods, into our communities, we're going to lose the war on COVID, and more casualties will continue to occur. We need to retool the nonprofits, just like we retooled car manufacturers, we retooled industry to build ventilators, to build respirators. We need to bring back those resources. We need boots on the ground, being able to reach out, the harder reach population, be able to change behaviors, being able to address the social determinants of health. If we don't address this in the entire picture, we're going to lose the war because we're always going to be on reactive mode. We should have been on proactive mode long ago, months ago, but we need to start now. And if I can get a message out to the governor, is we need that investment. The largest issues, we're already 85% Latinos. You know, we keep talking about the numbers that were already shared, that consistently Latinos numbers kept increasing while some of the other ones were a little bit slowing down or stabilizing. Latinos and communities of color and in the conditions where these inequities exist is where COVID was thriving. Again, if we don't address these inequities, we're not going to win the war on COVID. We have to have the political will. We have to have the investment, and this is not a time for political divisions. We really need a legislature at the state level. We need a governor, and we need a president, and we need a federal administration to step up and address these issues that have been documented for decades upon decades. Is it because we're Latino? Is it because we're low income? You know, what is it? There is no excuse. And now, you know, all these years where the can has been kicked down the road, we ran out of road.
On June 3rd, the Imperial Valley Board of Supervisors appealed to Governor Newsom that this entire state move ahead to stage 2B, which would be a departure from the county by county movement toward reopening that Imperial County would be very far away from qualifying for. So we understood this to be as an ask for an exemption from county metrics on account of unique conditions of the borderlands. So we started a petition of a group of concerned friends that quickly turned into a pretty large list of folks who gave us testimonies, and we sort of wrote a rebuttal to the governor. We wrote press releases and were successful at getting the media attention. And a few weeks and later, we think in part from these efforts, but also because of the media attention and because of just how severe the crisis was getting. Already in June 3rd, when the county sent this, we were at the top of the charts for the state, #1 on both deaths and infections. We've remained at that position, but the metrics are just worse. The governor sort of, I think, recognizing these things, asked not only sort of denying that request from the board, but sort of a request that they move back to something like stay at home. Since then, sort of, we think a lot of the things we were advocating for, we've made strides on. There's been a focus on resources as opposed to sort of the date of reopening. We're sort of still concerned about the lack of accountability that's built into the county response. All the language is in terms of strongly encouraging a series of measures with no sort of mechanisms for accountability. But we're turning now to working with other coalitions like the Comité Cívico, the Imperial Valley Community Health Coalition, and others to push it for an equity focus on sort of where we go now. So I'll say really briefly some major takeaway, and then some of the specific things we're sort of pushing for now. So some things that we sort of, I think, are pushing for is first this sort of false choice, or an artificial choice between sort of economic stability and public health, right? And I think Professor Flores' research is sort of speaking to this. This is an artificial choice because with the proper and accessible economic supports and safety nets, workers and small business owners don't have to make these choices about sort of going home if they're sick or not feeling well, fearing getting tested because they may jeopardize their economic stability, or small businesses feeling like they have to expose themselves in order to sort of keep their business. So, right, this is an artificial choice. And the county sort of was initially sort of making this argument, and we've sort of pushed back on it. The second thing is that we're pushing back at what I think is kind of a border exceptionalism, the sense that the problems of Imperial County are so exceptional, they're so particularistic that they sort of are must be, you know, that they either require different metrics or are not part of broader trends. And what we're pushing for, I think, is rather than treating the Imperial County as exceptional, that it's simply a very dramatic version of inequalities that are common in immigrant communities, low-income working class communities across the country. So there is a transnational twist to sort of to how dramatic our crisis is, and we know that workers of color across the country have to sort of traverse long distances in risky public transit to work in low wage and sort of precarious jobs. That's happening in the county across an international frontier, but it is a labor problem, right? It's not this exceptional problem that we can't sort of measure and sort of understand in the same way that we understand racial and socioeconomic injustices in other places. So we're trying to say we're a dramatic but not exceptional version of things that are going on elsewhere. So the same kinds of tools with more resources sort of should be applied here that we use for addressing inequities in other places. So to close, some of the things we're pushing for now. So we're collaborating with the local ACLU to really push for data on disparities, for equity data. We don't have data on where the workplaces where people are getting this we don't have socioeconomic data, and we don't even have robust racial data. So policy is just happening in the dark, and there's no data to inform interventions that Professor Flores' research shows should be focusing on workplace, the enforcement of workplace safety nets, these sorts of things, and also the multi-generational character of households. We're pushing for clear mechanisms of accountability. Again, it's not only about private behavior, but it is about workplaces, which means holding large-scale farmers and large retailers accountable. That is not happening. It means addressing housing precarity. Low-wage workers are also higher risk of experiencing housing insecurity. So right now we're pushing at the city level to pass city-level housing sort of eviction moratoriums, like sort of the governor has allowed us. And finally, sort of we're really pushing for the workplace dimension of this to make the rights and assistance that already do exist known and accessible, because even when they're out there, it's not enough to just sort of post them on social media or to sort of announce them. They need to be made accessible to people that are often Spanish speakers, may have connectivity issues with internet, and have discomfort with bureaucratic sort of language and things.
But what I see is that on a consistent basis is that I have patients who are lacking the education on how to improve their condition. Obviously, I think that there is a huge disparity with Hispanics and diabetes and all the other cardiovascular risks. However, they come to me and they truly do not know how to manage their diabetes. I have patients who don't monitor their blood glucose levels, are eating all the wrong things. They have to go to work, so they have families to support and things like that. They don't even come in to get their medications regularly checked and refilled and so forth. I have patients who tell me that they borrow their sister's, uncle's, friends' medication. I took this because she had this. So there is a severe lack of education that's going on here. And this is a major component as to why COVID is so high.
That people may not be educated about their own pre-existing conditions, let's call them that way, but do they have access to enough education? Do they have access to enough medical care, given that we know this is a medically underserved community?
No. Yes, they have access in the sense that we have a clinic there. However, there are so many patients that we have that just do not get the appointments that they need due to whatever reason. They're working and they can't do it. They don't know how to operate their phones and things like that. So when I see patients, I'm lucky if I get to see them via camera. Sometimes it's just via phone. And so there's so much more you can do with a face-to-face consultation versus on the phone. So yes, they have the ability to do so. However, lacking the proper knowledge on how important it is to take care of your health and things like that, I think that's what's missing. I think we need to spread that message and make that clear. Diabetes is a severe condition, and thus, you know, it affects every organ in your body. You know, I cannot begin to tell you how many patients I have who are they lack the education with nutrition, and going through their diets with them, it's like there's something missing. They do not see the connection, and that's where I am so happy to be able to provide them with that knowledge that I have, and in hopes that, you know, if I can change the life of one patient who can then change the life of their family or friend, that makes me happy.
We've been obviously dealing with this since the beginning, trying to engage the agricultural communities, but first by starting to send out letters asking the growers, contractors, and others to step up immediately. Unfortunately, those letters went unheeded because most growers continue to work and do operations as normal. And we're now seeing the effects of that throughout the entire country, California, obviously. And I can see that we have three major issues we're facing. One, wherever there is close contact, such as H2A workers, having to carpool together, having to live together, there's a higher propensity of infection. Facilities that have a lot of surface space, such as packing houses, production facilities, etc., that workers can touch more often. We're seeing a lot more outbreaks there. As a matter of fact, we're dealing with one right now, not in Imperial County, but it's in Wasco, California, where one processing facility has 91 employees that are infected, 36 family members, 23 children, for a total of 150 coming out of one facility. And all because the employer wanted to keep things quiet because they wanted production. They did not want their production impacted. And so they literally did not communicate with their employees about what was happening to try to stem the spread. And similarly with guest workers, as they're carpooling, we're seeing operations in Salinas where 150 workers are housed together. It's starting to spread. King City starting to spread. And the third part of it, which is also going to cause huge issues, is employers are refusing or failing to pay the employees for the CARES Act sick pay. As you all know or may know, California expanded it to include the food supply chain so that regardless of size of the employer, it would also apply. But we're hearing countless of workers left and right trying to figure out what to do because their employers refusing to pay them for either coming positive, having to quarantine themselves because their loved one is positive, or just outright terminating them, and that's how they're dealing with it. Not everybody. You know, I also want to stress that not everybody does that. We also have some of our unionized employers are just going above and beyond, saying, hey, if you're 65 years old or older, we're going to pay you to stay home if you want to. If you have any symptoms, stay home. We'll take care of you. And being very proactive by also socially distancing, but and adding additional safety precautions. But I think it's spreading as now that the harvests are going on a lot more throughout California, throughout the nation. It's definitely spreading a lot faster. And with employers now basically continuing operations as usual, and even blaming the employees that that's their fault because they didn't take care of themselves. So we're definitely seeing a lot more of that. And with the undocumented status of most of the agricultural community, that's even harder. With guest workers being deathly afraid, not just for their health, but for their family's financial income, because if they say something, they are totally afraid that they might not be brought back the following year. So all those different variables are contributing to the spread, in my opinion.